It is now my pleasure to introduce to you our session sponsor, Kate Mercier, who is the Chief Operating Officer of Norwell VNA, the sponsor NVNA. Kate, please join us.
Hey, good evening, everyone. So we are so grateful to be here with all of you tonight, and I just want to do a quick introduction to our organization. So we are NVNA and Hospice. We are a nonprofit provider of home care, palliative, and hospice services in Massachusetts. And we just gave a brief little synopsis of what our organization does, and we do obviously a lot more than what can fit on this one page, but we're very proud of what we do. And we serve 27 towns in our region, and we provide the full continuum of care. You can go to the next slide. So again, as you can see here, we are a Massachusetts provider. We serve Boston South Shore. We serve all the way from Milton, Quincy, all the way down to almost the Cape, for those of you who know that area, down to Carver and Plymouth. We have about 650 patients on our home care census on a day-to-day basis. And within that home care census, we provide palliative and advanced illness services. We also have about 150 patients that we serve with our hospice program. We also provide private duty, and we're just very lucky to be here, and I'm excited to introduce the presenter. So Nicole DePace, we have worked together at NVNA and Hospice for over a year at this point. Feels longer sometimes just because of the amount of work that we've been able to accomplish and the success we've had with our palliative program. So she is the director of Community Palliative Care Programs and Palliative Care Nurse Practitioner at NVNA and Hospice. She is also a PhD student at UMass Boston, president of the Boston chapter of the Hospice and Palliative Nurses Association, co-chair, Community Palliative Care Group of the Hospice and Palliative Care Federation of Mass, geriatric nurse practitioner, hospice and palliative care nurse practitioner, community-based provider, home inpatient assisted living, and skilled nursing facility and long-term care. And again, Nicole is very accomplished, but what I really wanted to say about Nicole tonight before she starts her presentation is that she truly is a compassionate provider of palliative and advanced illness practice. Again, in the short time that we've been able to work together, she's truly transformed palliative practice at NVNA and Hospice, and she really has focused on advanced illness management and really been working with our interdisciplinary teams, provided a lot of education to them. She really emphasizes case management, and she truly has compassion for not only our patients, but our practitioners and providers, and she truly wants to impact population health. I feel very grateful to work with Nicole, and I'm very excited to see her presentation tonight. So thank you so much.
Thank you very much for that warm introduction. I am happy to be here, and was very excited that I was asked to do this. I have formed a relationship with the Case Management Society of America in terms of being asked to write an article and a blog related to palliative care. And honestly, that connection came through a colleague who I believe is a member of the New England chapter, and just through networking and being willing to say yes when I was asked to provide some information and education to your organization. So I'm very happy to be here. I do work on the South Shore. I live in Boston, and I have been practicing in Massachusetts for 14 years now, but prior to that, I was a nurse at Mount Sinai Hospital in Manhattan, and I was a hospice nurse case manager in the Upper East Side and Spanish Harlem in New York City. So I feel really excited that there are folks not just from Massachusetts and New England, but also extending, throughout the Northeast. And anytime New York City is involved, my heart does a little pitter patter. So With that, I will jump into the presentation. And if you have questions, I believe they're going to be managed through the Q&A function. I will take a couple of pauses for questions, and then I hope that we'll have some discussion and dialogue at the end of my presentation, so please don't be shy. The objectives are fairly straightforward. I really want to spend some time defining the role of palliative care in meeting the needs of patients and families who live with serious illness, discuss the care settings where palliative care is and can be provided, and spend a lot of time talking about the role of the case manager in addressing palliative care needs and influencing the care decisions for patients who are living with serious illness. So some things that I just want to, overarching and big picture viewpoint of this and why it's so important. So we know that the population of patients who are living with serious illness in the United States is growing rapidly. And the needs of this patient population are long-term and complex. And this patient population in particular is at high risk for burdensome care transition, especially as they get closer to end of life. There's an incredible need for skilled and compassionate palliative care, and this is really a human right of all patients who live with serious illness. Palliative care is appropriate and should be provided to patients of any age, at any stage of their illness, and across all care settings. And case managers have a vital role to play in addressing the palliative care needs of patients who are living with serious illness. So we know that in terms of just the population of older adults in the United States, that this population is exploding. And many of these patients are living with some combination of frailty, physical and cognitive disabilities, multiple chronic illnesses, and functional limitations. So again, this speaks to that complexity and long-term care need that this patient population has and their risk for care transitions. The population of the United States is also increasingly culturally diverse, and organizations and clinicians have to be prepared to provide culturally safe care, especially in patients who are nearing end of life. And we know that marginalized populations do not appreciate the same access to palliative care, end of life care as white patients. So when we think about racially and ethnically minoritized populations, immigrant populations, and then subpopulations of patients with serious illness. So complicating factors in terms of people who are also dealing with substance use disorders, who are experiencing homelessness, or who have serious psychiatric conditions. All of those patient groups are at higher risk for more burdensome transitions and having their complex needs go unmet. And there is and always will be a need for palliative care specialists to lead, to provide the specialist care that's focused on the complex needs of patients with serious illness. But we also know that there are not enough palliative care specialists to provide the care for all of these patients. So how can every clinician build the skills and assess the needs of these patients and ensure that those needs do not go unmet? So as I talk more about some of the key concepts, I want to provide a framework from which to view this. So I'm going to talk about two patients that we're going to revisit at the end of this presentation. But thinking about the example of Maria, who's a 48-year-old woman who has a history of cervical cancer that was successfully treated with surgery, chemotherapy, and radiation. She currently has no evidence of disease, and so she's no longer actively followed by her oncology team. However, her cancer treatment has left her with significant disability due to chronic lower extremity lymphedema and severe pelvic pain, and she requires high-dose opioids to manage this. She also lives with bipolar disorder and anxiety, and unfortunately has end-stage renal disease and is requiring dialysis. Her primary care physician no longer feels comfortable prescribing her opioids given her increasing medical complexity and her need for close monitoring. She lives with her partner in the community who works full-time, and otherwise she only has limited social supports. We also have Gerald, who's an 84-year-old man with Parkinson's disease. He has a history of a stroke, atrial fibrillation. He is on a blood thinner, anticoagulation. He has anemia and he's hard of hearing. He's been hospitalized twice in the past 6 months due to severe anemia that is likely due to gastrointestinal bleeding, but a specific source has not been identified. He has required blood transfusion during each of these hospitalizations. In the community, he's followed by a primary care physician, a cardiologist, a gastroenterologist, and a neurologist. He lives at home in the community with the support of private caregivers and his elderly sister, who is also his healthcare proxy, or in some states, this would be called the durable power of attorney. He has expressed to his care team that he does not want to return to the hospital, and he and his sister both want to know how his anemia can be managed in the outpatient setting. He has not completed an advanced directive like a MOLST or a POLST, depending on what state you live in terms of what that document is called. So just think about these patients as we talk about these concepts. So first, we can talk a little bit about what is serious illness. So there is no one agreed upon definition. It does, however, we know that these illnesses carry a high risk of mortality, and they negatively impact a person's daily functioning or quality of life, and or excessively strain the caregivers. And there are significant structural issues that create barriers to meeting the needs of the patients who live with serious illness. So what does it mean, those structural issues? So things that are considered structural would be waste in the utilization of resources, misaligned financial incentives, a fragmented care delivery system, time pressures that limit communication with patients and families, and a lack of service coordination across programs. So it's our job to recognize structural barriers that create inequity in access to palliative care for underserved populations and work to connect patients and families with the services they need and that they can readily connect with. So what are the needs of people with serious illness? And I use the imagery of an iceberg because oftentimes we're responding to the things that are the tip of the iceberg or that are easily visible. But knowing that this patient population is experiencing a whole host of issues and stressors that are often invisible to their care teams. So individuals who are seriously ill need care that is seamless across all care settings, that rapidly responds to their needs and changes in their status, and that is aligned with their preferences and goals. Providing crisis care to individuals with a serious illness whose ongoing care needs are poorly managed results in increased healthcare spending that also does not end up improving their quality of life. And the care of individuals with serious illness is often marked by inadequate symptom control and low patient and family perceptions of quality of care, and oftentimes, unfortunately, is not in line with their goals and preferences. Patients with serious illness and their family caregivers are seldom able to have their care needs reliably met, which leads to symptom exacerbation crises and emergency department visits or repeated hospitalizations. So we know that we have numerous opportunities across care settings to address these needs, and case managers are uniquely positioned to influence the care delivery of this patient population. So first, patients need to understand that they have a serious illness. So a lot of what they need is communication and education. They also want to know what palliative care is. And I highlight this because a lot of times when we do get into conversations with patients and families or even care teams about palliative care, we spend a lot of time trying to talk about what it is not, to put people at ease or to try and encourage them to engage with the support. So what I'm talking about is when we say things like, well, it's not hospice, or it's not going to limit your treatment options, but that doesn't help people understand what it is, nor is it an effective strategy on its own to help allay their fears and accept the support. As case managers, you possess the skills and trust that is required to communicate with patients about their illness and palliative care. And you all are experts at exploring patients and families' understanding of their illness, their treatment options, identifying psychosocial and emotional needs of patients and families, and help them work through these conversations and decisions. You are, and you do provide an extra layer of support and follow-up for patients and families who experience a higher level of anxiety with some of these conversations. So to define what is palliative care. Palliative care, in its simplest terms, is care for people who are seriously ill that focuses on what is most important to them and their families. It is whole person, family-centered care. And palliative care specialists focus on preventing and relieving suffering through a holistic approach to patient and family care by addressing issues that are physical, psychosocial, and spiritual in nature. It is specialty level care for patients who live with a serious illness, and again, provides relief from distressing symptoms and improves quality of life, and acknowledges and deals with the stressors that patients and families face when they're dealing with the challenges of their serious illness. It is also holistic care. It's meant to be interdisciplinary and provided by a team. So it's not just meant to be provided by physicians or nurse practitioners or nurses only or social workers or spiritual care providers. It requires all hands on deck. So it's a team-based approach that does include physicians, nurses, social workers, spiritual care providers, pharmacists, psychologists, case managers, physical therapists, home health aides. It's whoever's participating in the care of that patient and family and contributing to a plan of care that's helping to reduce suffering and respect their wishes. So when we talk about what the physical, spiritual, social, psychological needs are, that can sound straightforward, but if we take an issue like, for instance, constipation. So if we think that it's very straightforward to deal with constipation, and that's a physical symptom, which on the surface should be easy to manage. And yes, we can and should be able to manage that. But when we think about constipation in a person with a serious illness and the physical aspects of that, yes, we're talking about their bowels and elimination status, but we're probably also talking about at this point their functional status. Are they still able to get up and get out of bed and toilet the way that they would like to? Are they needing adaptive equipment? Have they lost control of this bodily function? So how can that affect somebody socially? For instance, if they are no longer independent in their mobility, or they've lost control of their bowels, how does that affect them socially? Is it contributing to isolation? Is it contributing to caregiver burden? If we think about psychologically, if we have a person who won't adhere to their bowel regimen and we're frustrated, perhaps they have high anxiety around not wanting to have an accident. They won't take their bowel medications on certain days or with certain activities, or when they know that they have an appointment with their physician, because God forbid they don't want to have an accident in the car, or bathrooms out of their home are not accessible. So all of those things come into play spiritually. Is this affecting this person's ability to cope around losing hope or having anger around whatever's going on with their physical function and illness? Is it affecting if they are a person of faith, is it affecting their relationship in terms of their belief system? So one symptom that feels very straightforward can have an incredible impact on a patient and a family. And a palliative care clinician and a palliative care approach would look at this very holistically and try to understand how this symptom is affecting this person across all aspects of their lives, and also thinking about how it might be affecting their caregiver or family unit. So where is palliative care provided? A lot of palliative care is provided in hospitals and clinic settings. But an increasing number of palliative care encounters and services occur in the community, meaning occurring anywhere outside of the hospital. So in patients' homes, in assisted living communities, in skilled nursing facilities, in long-term care, in group homes, anywhere where patients live. And the community-based support is actually incredibly important. Patients don't live in hospitals. So we want to help them get the support that they need to be successful in the community even when they're facing, and especially when they're facing a serious illness and all the changes and stressors that come with that. So again, if palliative care is appropriate and can and should be provided to patients of any age at any stage of their illness and across all care settings. It's available in hospitals, clinics, skilled nursing facilities, assisted living communities, and in patients' homes. This, however, does not mean that your community where you work and live has palliative care that's accessible in all these sites of care. So understanding your community and its resources are important. Most community-based palliative care services that are provided to patients in their homes are done so through either hospital systems or hospice organizations. In 2019, the Center to Advance Palliative Care published their report, Mapping Community-Based Palliative Care, and it found that community-based palliative care programs are operated by a variety of organizations. And second to hospitals and hospices, home health agencies, long-term care facilities, and clinics are also the top providers of community-based palliative care services. So I want to, if I may, just take a pause here and see if anybody, through using the Q&A function, has experience or wants to say a little bit about what palliative care supports exist in your community that's not hospital-based. So maybe just, using the hand function, who has access to community-based palliative care, and does anybody have a quick comment that you want to make about trying to refer or connect with palliative care services in your community? And for those who have responded or who are still thinking, what are some of the top barriers that you think exist in regards to trying to connect patients with palliative care service providers? So I can see a couple comments. One is that generally offered through hospice agencies, there does not seem to be many palliative care providers in this area, and the ones that exist are underutilized. It's hard for patients to understand what palliative care can do for them. Cancer centers might provide the support. I worked with one and it was great to see them assist the patients. I'm not 100% sure what this means, but self-pay patients, so maybe the payer source or lack of a payer source. One person finds them easily accessible, but there's very poor understanding of the services. Understanding what it is and getting the providers, especially the oncologists, to write an order. Somebody who works with the VA of Hudson Valley, we have an excellent outpatient palliative care program. The biggest barrier is getting patients to accept it, getting primary care providers to buy in, the lack of physician understanding when to use it versus hospice. The physicians, again, might be a barrier. Limited staffing availability, and COVID has made this harder. Oncologists seem to be hesitant. The members, so I would translate this to the patients, don't understand what it is. Someone who was retired from Aetna offered a compassionate care program for hospice patients where they could have concurrent curative care in addition to hospice. So again, those treatment decisions and the insurance and regulatory issues can really be challenging. And a lot of times patients may not feel that it's necessary. So I think that that's a really good list and very common barriers. And wherever you're working and practicing, you're not alone. These are challenges that no matter which part of the country you're in and how well resourced you are, these issues come up all the time. So thank you for humoring me and being very willing to participate with that. Okay, so this, okay. So in terms of access with palliative care and knowing that everyone who's on this Zoom this evening represents a region of the United States, and thinking about all the variability that might exist just in your city or your geography or your state, and then when we talk about a region, and then zooming that out and thinking about access in the entire country. So in the United States, most specialty level palliative care services are provided to individuals who are admitted to the hospital. And 94% of hospitals with more than 300 beds and 72% of hospitals who have more than 50 beds provide some level of palliative care services. And there's a lot of variability even when we're talking about palliative care in the hospital. So if you're working in an urban academic medical center, your palliative care team in the hospital is highly likely to look very different than a palliative care service or a palliative care team in a rural community-based hospital that serves a rural community that has maybe 112 beds. If there are palliative care services, the level of resource and capacity is going to be very different. And then when you think about if you're talking about providing home-based palliative care services in a very urban environment like New York City versus New Hampshire bordering the Canadian border, or in rural parts of Maine or Western New York or Western Massachusetts, that's going to look very different in terms of your patient populations, the resources available to you, and the best way to connect with those services. There are a lot of geographic variations in availability and quality of palliative care services in the US. Fortunately, the majority of individuals in the Northeast, as well as the Mountain West, have almost universal access to palliative care in terms of hospital-based support. Compared to if we talk about the South Central United States, where only 1/3 of hospitals provide some sort of palliative care support in the hospital. We also know that individuals who live in rural areas are much less likely to have access to palliative care compared to those who live in urban areas. And there's a lot of variability in the services available in each community. So as case managers, part of your expertise is understanding your health system and your community's palliative care resources, and knowing that those resources often change. This is a model depicting palliative care delivery for the 21st century. And it was published by Hawley in 2014. And what this is really depicting is this pink triangle or arrow represents palliative care, and this blue triangle represents traditional or primary medical management of a chronic or serious illness. And so what you see over time is that as the disease either progresses or improves, the disease management focus diminishes, and the palliative care emphasis expands. And in this 21st century model of palliative care, what this is trying to depict is a framework in which to present palliative care to both patients, but also physicians, that if we're talking about trying to get palliative care involved upstream, we also have to provide conversations and options of two paths for patients as they go through treatment. That it may include through end-of-life care and needing hospice, or it might include survivorship and needing to include more rehabilitation and how to help that person live as a person who has survived the treatment of a serious illness. We know that most patients will not go on to survivorship, however, some do. And we also know that early integration of palliative care is incredibly beneficial to patients. We also know, and there's good understanding through research in the literature, that actually achieving early integration of palliative care is very difficult. So one of the ways to overcome the challenges is to ensure that we're talking about it with paths to either end-of-life care or survivorship with the early integration of palliative care. Unfortunately, late referrals and inadequate resources are very common in terms of palliative care delivery, as well as in palliative care programs. So the ability to achieve maximum potential, both for the relief of suffering and to reduce the cost of medical care, can be diminished. If early integration of palliative care with disease management is the goal, then the possibility of cure must still be recognized when considering a referral, at least in the short term. The excellent work that palliative care teams can do with patients who have difficulty accepting their own mortality can only be done once we have contact with them. So we really can't do this work if we're not invited to participate. And Holly's intention in communicating what she called the bow tie model was to facilitate earlier acceptance of the role of palliative care for people who are diagnosed with serious illness, whether their illness was considered to be fatal or not. So in essence, what this is saying is we don't need to know whether or not this illness is terminal or going to be fatal when we decide to include palliative care. And in fact, the option for cure or the hope for surviving the illness can still very much be on the table. And another aspect of providing palliative care in the 21st century, which I alluded to in one of the earlier slides, is that the population of people who are living with serious illness is increasing rapidly, and the workforce of palliative care specialists was not adequate prior to the explosion of this population and prior to COVID. And through COVID, and as this population continues to grow, the supply of palliative care specialists cannot and will not keep pace with the demand of the serious ill population. So this means that all clinicians need to have a primary palliative care skill set or toolbox, including case managers. So what are primary palliative care skills? That includes competence in basic assessment of management of pain and symptoms, the ability to assess and reduce emotional stress and burdens to the patient and family, being able to assist with advanced care planning and serious illness conversations, providing coordination of care across the patient's care team and settings, and understanding when and how to refer to specialty level palliative care when the problems become more complex or severe. And the role of specialty level palliative care clinicians and services is to provide assessment and management of complex or refractory pain or other symptoms, assessment and management of more complex anxiety, depression, grief, and existential distress, to assist with conflicts around the goals of care or other treatment options. And these conflicts could occur within families, between staff and families, or among treatment teams, and to assist in addressing cases of medical futility or when patients' families or teams want to pursue non-beneficial medical care. And again, case managers play an essential role in both the primary palliative care skills or addressing the primary palliative care needs of patients, as well as ensuring access to specialty level palliative care when it's required. And the effects of COVID-19 have highlighted how crucial it is for every clinician to gain this fundamental knowledge in terms of primary palliative care. And what are the basics of referral criteria for palliative care support? So we first want to make sure that the patient has a serious illness diagnosis and that we understand what that is. We also want to be able to communicate this to patients. Oftentimes they don't understand their illness or the implications or the treatments. And sometimes where we have to start is as simple as explaining to them, you have a serious illness, or your chronic kidney disease is a serious illness, and we need to include other layers of support to meet your needs. But we're talking, this again is not an exhaustive list. There are many things that are not listed here that would qualify as a serious illness, but the nuts and bolts or the bread and butter are people who have metastatic or recurrent cancer, people living with advanced heart failure, so New York Heart Association class 3 or 4, advanced COPD or other pulmonary disorders, chronic kidney disease at stage 4 or 5, and they could be pursuing dialysis or not, patients with liver failure who have progressive neurological disorders, things like ALS, Parkinson's, MSA, PSP, and those patients with dementia illnesses. And when we're talking about palliative care referrals, we're really thinking about patients with mid and late stage dementia illnesses. And then we're looking at, do they have any of these other issues going on? So do they have an unacceptable symptom burden? Symptoms can be things like pain, shortness of breath, fatigue, anxiety, depression, loss of appetite, nausea, constipation. There could also be a million things on this list that are not listed here that a person might be struggling with in terms of a symptom of their illness or the treatment of their illness. Then we want to think about their utilization. Are they having frequent emergency room visits for similar issues? Have there been 3 or more hospitalizations within the past year for similar issues? Or do they have prolonged utilization of rehab services with minimal improvement in their functional status? There also could be other things that you would look at in terms of utilization as a trigger for a palliative care referral. We want to look at conflict and uncertainty. Is there uncertainty about the prognosis and or the treatment options? This uncertainty could be coming from the patient and family. It could also be coming from the clinicians involved in their care. Are there conflicts around do not resuscitate orders or around decision-making for things like artificial nutrition and hydration? Is the patient or family requesting fetal medical care? And then we want to look at psychosocial factors. So we know that our patients who have very limited social supports are going to be at higher risk for poor outcomes. The populations of patients who are dealing with homelessness, who have chronic mental illness, substance use disorders, or very complex family dynamics, or who lack any sort of caregiver. Patients who are experiencing a high level of psychological, emotional, or spiritual distress related to their serious illness. And those patients and families who have either a high risk for caregiver burnout or a burnt out caregiver. So these are all factors that contribute to triggers for palliative care referrals for patients who are living with serious illness. This is, again, not the end all be all. There are other mechanisms, there are other factors to take into consideration, but this is, these are sort of the high level things that we want to look at, and in terms of justifying, but also framing it if we're presenting it back to a physician colleague who's hesitant, to be able to spell it out very clearly and concisely about why we're asking for the support and what we expect palliative care resources to do once they get involved in the case. So what is the role of case management? So if we think back to Maria and Gerald and applying the information that's been presented thus far, what would the role of the case manager be in addressing the palliative care needs of either Maria or Gerald? What is the role of palliative care if they were to get involved in addressing either Maria or Gerald's needs? And in what settings could palliative care be provided to either Maria or Gerald? As case managers, I know that you do not establish diagnoses or make treatment decisions, but you do advocate for your patients and you do guide referrals to appropriate specialty services. And you can be very effective at guiding referrals to palliative care resources when they're needed for your patients. You're also experts in identifying unmet needs and creating plans to address those needs. So thinking about applying your expertise in assessment and planning for patients, particularly patients with complex needs. How do you apply your expertise and your skill in coordinating care and evaluating the effectiveness of the plan that's been put in place? Particularly evaluating the effectiveness of a plan that includes multiple service providers or multiple sites of care for patients and families. You're really good at talking to people. You're really good at talking to patients and families and multiple stakeholders involved in the care. So leaning into conversations where you're exploring patient and families' understanding of their illness and their treatment. Exploring what kind of education and support they need to make decisions. And raising the flags and alerting providers and teams when there are unmet needs and patients do need referrals or they need follow-up from their treating team, that there are conflicts going on around decision-making or wishes for treatment. You guys are experts at this. And these are all crucial aspects of those primary palliative care skill sets that you already possess. You're also incredible influencers in terms of patients' care and in care teams. And I would say influencing care is an essential function of case management. You operate as patient advocates and you're change agents for patient and families in terms of their care. This is very important because we know that at least half of patients who have serious illness will experience one or more transfer in their last month of life. And this illustrates the incredible need for effective communication and coordination of care in order to protect the dignity and comfort of these patients and ensure that their wishes are heard and respected. And again, you all are the folks on the team who are often playing a pivotal role in alerting the primary care team when patients and families are expressing readiness to do things like complete advance directives, to accept referrals to resources, such as including a palliative care specialist or making a referral to palliative care, and advocating for those changes in the plan to be made. And so much of what we do and what patients with serious illness need centers around communication and coordination of care. It's incredibly important that we have the time to really sit and talk with these patients and families and understand what they know, what they don't know, what's important to them, what's become a burden to them, where they want to be, how they want to receive their care, and what their caregivers need in order to facilitate those wishes coming true. It's essential that we have skilled and compassionate communication and that we coordinate care in a way that meets these needs, because we're trying to ensure that a person's dignity is respected, that it's revered, and that it's upheld. We're trying to ensure that they have comfort, and we want to make sure that they feel respected. And a very important part of feeling respected is feeling heard and feeling seen and feeling understood and listened to. Case managers, this is, I feel, the heart of your work, and what you do is centered around patient wishes. And again, in the previous slide we talked about, but a big part of what you do is alert the treating team about what the patient's needs are, what their wishes are, and what needs to be followed up on. Part of this communication and coordination of care might be that you understand that a family meeting is going to be necessary to address the issues around decision-making for medical care, or when there's conflict about making referrals to resources like specialty palliative care, and how to resolve those conflicts to ensure that the patient and family get adequate support. So I'm wondering if we can take another quick pause, and if folks want to share what some of your biggest struggles are or successes are with communicating with patients and families around serious illness. So either the things that make you feel tongue-tied or the things that help motivate you and make you feel most successful with this. Everyone feeling a little more shy with this question? Yeah, I can see that dealing with conflict and with the patients and the families, how to get everyone around that table to discuss the patient's needs. That's a big one. So restating the question, I think the heart of the question is, what are the things that you find are the biggest barriers for communication around serious illness or palliative care with patients and families? Or what are the things that are most motivating or help you lean into these conversations? Yeah, finding the time in the midst of a crazy workday, getting multiple family members together with the patient to make these decisions. Just getting the conversation started can be tough. If the provider has not communicated how advanced the disease is, has found that getting a community nurse practitioner involved has been crucial to getting the patient what they need. When the family have goals that are in conflict with what the patient wants, when there are language and cultural differences. Yeah, when their patient is compromised and to make decisions very late in life. So when these conversations are happening very late can be really tough for a variety of reasons. And that doing this with interdisciplinary teamwork and discussion is helpful for unified messaging. And things like dealing with denial can be really tough. So yeah, I think those are some of the biggest barriers, is when we have multiple folks who need to participate in the conversation, and how do we get them all at the table, so to speak? What do we do when patients and families aren't in agreement or maybe not willing to speak openly? What do we do when we have to use an interpreter or we don't speak the patient and family's language, and or there might be, if it's not a language barrier, maybe there are cultural barriers going on, and we may not fully understand. And how do you elicit that in a conversation? And then dealing with a lack of transparency around prognosis or treatment when it hasn't been disclosed. I think those are all really big challenges. However, they are challenges. They don't need to be hard stops from having some of these conversations. And those identified barriers in and of themselves can and should be a trigger for maybe some palliative care specialist to get involved and provide support when available. Okay. So some key points before we revisit the cases. That palliative care is an extra layer of support. Case managers do provide primary palliative care. It's appropriate at any stage of an illness. It can be provided concurrently for patients who are receiving medical treatments for their serious illness. Patients can continue to see their primary medical providers and have palliative care specialists involved in their care. And palliative care specialists will provide expert level pain and symptom management. I want to go back to the cases of Maria and Gerald and frame this through the lens of what we've talked about. So I'm not going to read Maria's case again to you verbatim, but just thinking about this. So what is Maria's serious illness? I think first and foremost, when we want to try and address the needs of these patients or talk about how to guide referrals, for us to be very clear, what is the serious illness? And if we're not, what information do we need to make that more clear? And does the patient understand what their serious illness is? So in this case, Maria is a cancer survivor, but her cancer survival came at a great cost and created significant disability and lifelong severe pain. She also has now end-stage renal disease, which is her primary serious illness, and she's going to require hemodialysis. We're at an inflection point for her as well in terms of her journey, in terms of her health, because her primary care provider does not feel comfortable continuing to manage her pain. And she's not followed by oncology, and her nephrology team doesn't want to get involved in this. So she has an incredible unmet need. So when we think about that referral criteria, we would frame this in that her serious illness is her end-stage renal disease. She's going to require hemodialysis. She checks that box of having high symptom burden. So she's got complex pain that's severe and requires high dose opioids, and that we know that her pain is not going to remit. This is a chronic lifelong issue. And she requires that opioid treatment in terms of controlling her pain and for quality of life. From this case, her utilization of healthcare resources is not clear. But if we imagine use for a patient like this, we could assume that she's a person who has high utilization. And what if I shared that she'd had 2 hospitalizations in the past year for sepsis, and both required ICU stays and intubation? If we think about, is there conflict or uncertainty in this case? For her, the prognosis is not clear. And that's not necessarily because it hasn't been disclosed. It may be because it's just not clear. And it's not always clear to treating providers. And then what do you do? And how do you talk about that? And even though her prognosis is not clear, we do know that she's at high risk for a sudden decline or a sudden event, and even sudden death. What are the psychosocial factors that contribute to her needs for specialty level palliative care? We know that she has limited social supports. She also has comorbid serious psychiatric illness. She has bipolar disorder and anxiety, and she has limited caregiver support. So some questions I would like to, once I'm finished, for the group to discuss is, where could Maria receive palliative care support? And how would you approach making referrals for her? And if we use this framework to revisit Gerald. So what is his serious illness or illnesses? He has Parkinson's, he has cerebral vascular disease, and he's also got a severe anemia of unclear etiology. He's transfusion dependent. So he doesn't have one, he has multiple. His symptom burden. It's not clear from what's presented here, but we could assume that it fluctuates. And we could assume that perhaps fatigue and shortness of breath are worse when his blood counts drop, and that these symptoms are generally what precipitates the hospital admission. So this would be that crisis-driven care that we talked about. People with serious illness are at high risk of, and those transitions, as well as the things that we want to try really hard to prevent for this patient population. What is his healthcare utilization? He's had 2 hospitalizations in the past 6 months for severe anemia that require transfusion. He's gone through an extensive GI workup that was not conclusive. And we can also assume with all these specialists involved, he's having an increased frequency of visits to medical providers without stabilizing his condition. If we think about the conflict or uncertainty, first and foremost, he's expressing he does not want to go back to the hospital. So there's already a conflict if he doesn't have adequate support in the community or medical follow-up in the community to prevent that. His prognosis is also uncertain. However, he is also a patient who's at high risk for sudden complications and sudden death. His treatment teams, there does seem to be conflict. It's not explicit, but implicit in this is that he's on an anticoagulant and he's bleeding. He's bleeding so bad he needs blood transfusions and to be hospitalized. So can we say that his cardiologist, his gastroenterologist, and his primary care provider are aligned in his medical care? What are the psychosocial factors? We know that he's an elderly gentleman who lives in the community. He has limited family support, and he's supported with private caregivers. So to have some discussion about what is the role of the case manager in Gerald's care, what support does he need, and how might you approach communication with Gerald and his care team? Okay, so we've got one answer, and that was tied to Maria. So where can she receive palliative care support? And that would be in the home. And that is correct. She could definitely receive support in the home. Are there other mechanisms for her to get palliative care support? So really anywhere Maria goes, that we should be exploring whether or not there's a resource for palliative care for her. So if she's admitted to the hospital, again, if she presents to the ED, is there anything that's clinic-based in terms of partnering with whoever's going to be providing her dialysis? And definitely home-based support. But she's going to need a referral for pain management. That's the priority, is she's not going to have access to pain management going forward. So whether it's home-based palliative care who can help with that prescriptive authority, or who can partner with the PCP so they feel comfortable that she has enough monitoring to continue to prescribe. Does she need a clinic with a prescriber who's willing to take on her pain management and provide adequate oversight? But that's one of her primary needs. Also thinking about how to layer in other social supports for her in the home and community setting, and probably coordinating some care with her dialysis clinic. And typically there's a social worker, so trying to align the members of the team who are already involved in her care to layer in additional support and oversight for her care. How might you suggest presenting palliative care to Maria if we find that she is reluctant to have palliative care, a home-based palliative care provider come and see her? What might you do to encourage her or to explain to her what the benefit could be? And we have that it will not interfere with her medical care or her existing providers, that she would benefit from more in-home support through palliative care. So all of these are excellent options for communicating with her. But I think first and foremost, helping her to understand why her PCP would like more support and help in managing her pain, focusing on the unmet need and the need with the most immediacy. So that we need to, that this type of support, the focus of this type of support is in helping to ensure that she has access to pain management and to ensure that the prescribing of her opioids will not be interrupted, and that her safety and her comfort are going to be the focus of the palliative care involvement. Because what's the subtext of people being afraid or reluctant to have palliative care clinicians get involved in the care? Somebody put in all caps hospice. Yes. that, you know, and someone also said that she might feel that she'll lose control. And I think the fear of dying, the fear of hospice, the fear that they'll lose their doctors or the clinicians that they've known and who have participated in their care for a long time. So what can we do and what can we say to Maria to try and overcome some of those fears that she may have? We can educate, but what can we communicate? What would we want to say to Maria specifically? What we do, right? We can assure her that she'll be able to keep all of her doctors that she already knows, and that the focus will be on relieving her pain. So making sure that we stay focused on what palliative care will do. And if she's able to, if she's brave enough to say the thing she's afraid of, and that she's afraid it means she's dying, or she's afraid it's hospice, reassuring her and exploring with her what about that makes her so afraid. And then reassuring her that, you know, at this point in time, we don't have an understanding of where things are at, and that's okay in terms of her prognosis. She's pursuing dialysis, and this won't interfere with that. And I think centering on what palliative care is going to do and why you've asked them to participate in the plan of care. And I love that Christine said to make sure she's included in the care plan. Yeah, her voice and her needs should be centered, and she should feel like she has a say. And we definitely want to respect her need for control. Okay. So if we come back to Gerald, and let's say that we wanted to talk to Gerald's cardiologist, who still has him on his blood thinner, despite the fact that he's been in the hospital twice for significant bleeding and needed blood transfusions. How might we want to approach the referral for palliative care with his cardiologist? Linda, thank you for the humor. Linda just said good luck. We might need a little bit of luck. But does anybody have any ideas or experiences where you think you have some wisdom to share about how we might present this to the cardiologist? Okay, maybe talk with the nurse practitioner, if the physician assistant, if there's one in the office. So engaging other members of the interdisciplinary team to help guide the care. Talk about that palliative care is going to look at the whole person and all of the diagnoses and have a big picture view, and that they're not only coming in to think about the blood thinner or the cardiac issues. So recognizing and acknowledging this history of a CVA, and, you know, maybe exploring, you know, when a physician says no to palliative care, a good way to respond to that is not let that be the end of the conversation. Maybe say, oh, I'm surprised that the answer is no. Is there a specific concern that you have about palliative care being involved in the care of your patient? Understand exactly what is their worry. Is it that they think that it's hospice? Is it that they think that you're going to stop a treatment that they feel is important? Is it that they've had bad experiences in the past? You know, understanding from the physician's perspective what their hesitancy is a really important thing to do. So if there's a no, that doesn't have to be where the conversation ends. And in fact, it could be a great way to start a conversation to get a better understanding. We have also that you could just state the facts and schedule an appointment for the patient. The case manager could attend the appointment with the patient to advocate if the patient's not able to understand or advocate for themselves. Again, another person says to talk with the nurse in the cardiologist's office to help advance the issue and the cause. Keep the patient's wishes at the center. Acknowledge that some providers might feel that they're giving up. Try and advocate for the GI doc to talk with the cardiologist to have a bigger discussion about risks versus benefits. I think important things are, one, if there is a no, that starts a conversation, it doesn't end it. I love the input of engaging other members of the care team to champion the cause. I also think that alerting the cardiologist to the fact that he does not want to go back to the hospital. And if he's going to stay on anticoagulation, what can we do better for him to monitor his counts and connect him with resources for transfusions on an outpatient basis? Does his cardiologist think that he would be safe for outpatient transfusions if he has a risk for fluid overload? So engaging the physician who is resistant into having other options for the care plan and explaining to them that this is part of what we want the palliative care clinician to do, is to really have these in-depth, detailed conversations about the treatment options at a high level and what is best matched with the patient's wishes and needs. And also, this patient is expressing a wish to have advanced directives. He does not have a MOLST. He's a frail elder. And part of what we need the palliative care clinician to do, perhaps, any of his providers could do this, but perhaps what the palliative care clinician could be very effective at doing is getting something like a MOLST or a PULSE completed so that this gentleman's wishes can be well discussed, understood, and put in writing, so that if something sudden and catastrophic happens to him at home or in the community, he's not going to be put through the heroics of CPR if that's not what he wants, and at this point would not be of any benefit to him. So I think uplifting the patient's voice and helping the provider, if it's the provider who's the barrier, understand their role in ensuring that the patient's needs are respected, and that by writing the referral, they're participating in the plan of care and helping to ensure this gentleman's dignity and comfort, as well as helping him feel respected. There are other ideas, one referral on its own may not be enough. So does he need a home health referral? Yeah, I think there are other things that could be done to treat this gentleman if treatment are in line with his goals, and helping the cardiologist to understand that, but that with or without anticoagulation, he needs a different plan of care in the community to ensure that his needs are met and that we can help prevent another hospitalization, because that's not where he wants to be. And if and when he does have a complication that can't be managed in terms of treating the disease, when and how would he want to transition to something like hospice or comfort care, and having those discussions earlier rather than later to ensure that his wishes are respected. So I'm going to stop sharing, and I'm not sure where we're at on time, but open it up to any other final questions or comments if folks want to ask.
Hi, this is Teresa Peterson, and I'll facilitate any questions that are additional questions placed in the question and answer section of the Zoom meeting. And thank you, Nicole, for a very insightful meeting. Appreciate it.
Thank you for having me.
Our pleasure. Any additional questions for Nicole? Okay, Christine Coombs is asking, can you please comment on payer disbursements? And the second question is, patient candidate for insertion of an IV filter, and I'm assuming that last patient the last case summary that you reviewed. So first, can you please comment on payer reimbursements for palliative care?
Yes. So in terms of reimbursement, palliative care is not a funded benefit in the way that, for instance, hospice or home health is. So there's no specific Medicare benefit for palliative care in the community. The only payment mechanism, that exists from a Medicare standpoint for palliative care is under a fee-for-service model that would pay for services provided by a physician, a nurse practitioner, or a physician assistant. And that's in any setting, whether it's at home, in a clinic, in a nursing facility, an assisted living. It's billed like a doctor's office visit would be. It's just wherever that visit is occurring for that patient. And so that's one reimbursement mechanism that exists. Many managed care payers will reimburse in a fee-for-service capacity for the physician or advanced practice provider visits. There are some demonstration projects across the country, and there are very few ACOs who have sort of bundled payment services that may pay for some sort of palliative care service structure in the community setting. But there's a wide variability, and it's actually quite limited in terms of access to those types of resources, including in the Northeast. So the primary reimbursement structure is through a fee-for-service model through either Medicare or private insurers, and there can be variability state to state in terms of what Medicaid will reimburse, but when Medicaid reimburses, it's typically also under a fee-for-service model. So I hope that answered that person's question.
I feel like it has, along with another question we received from Lauren. Are there any insurance limitations on the coverage of palliative care services? And I think you've answered that as well. I just want to go back. The case summary, the last case summary, Catherine is asking if the patient would have been a candidate for insertion of an IVC filter.
Well, I think that in the information we have that I presented, that's unclear, but I can say that he's not on anticoagulation in terms of for a PE or a DVT. It's really because he has AFib and he has a history of stroke. So an IVC filter in that case is not, it's not an indication, nor is it going to probably alleviate any of this conflict around should he be on anticoagulation or should he not be. But in other instances of patients on anticoagulation, that is a very reasonable question to ask the treating team.
Understood. Linda's had a comment that she believes some of this falls under home care.
So home care, again, there's no separate benefit for palliative care under Medicare. Many home care organizations provide some aspect of palliative care service delivery, and if they are doing so, they are housing it under their home health program. So those patients, first and foremost, have to meet the criteria for home care. The certified home health services, meaning they have to be homebound and they have to have a skilled need. If an agency takes on the program development, but also risk and financial implications of layering on palliative care support within their home care framework, then that may, be within a home care program, but it's not because there's a separate palliative care benefit. And the home care regs require home care services to be short-term and intermittent. So it's not the best care delivery model for patients who have long-term needs related to a chronic and serious illness. There's still risk for some of that fragmented care. But home health agencies do this, and when they do it, either because it's mission-driven or an arrangement through an ACO, they've decided it's the right thing to do to take care of this patient population and to meet the very complex needs. And so I hope that answers that question as well.
I think it does. The next comment here we have from Lori. Honestly, I've never had a provider say no to palliative care. They love it and always appreciate the help. They do often have difficulty with prescribing pain meds, as the palliative NPs recommend they may be different meds than they usually go to. I think they want the NPs to prescribe. Linda's comment here is to, and it's a great plan, calling the patient's insurance company and ask for the nurse case manager to find out payment and in-network providers for palliative care, utilizing the insurance companies, the health plans you talked about, you had referred to.
That's right. And one other thing about health plans that I do want to mention. So if a patient is dually eligible and has Medicare and Medicaid and is enrolled in some sort of senior care options or managed sort of Medicaid program, sometimes within those payment models, there is infrastructure for more long-term home care supports or palliative care service provision that patients with traditional managed care products or who have straight Medicare or Medicaid may not appreciate. So it is always worth calling the insurance provider to see whether or not they have some sort of carve-out benefit for their members.
Sounds good. Is there any movement under CMS to add options for palliative care services? I think earlier you talked about demonstration projects. Have there been any additional ones, kind of proving their goals? Has there any movement under permanent movement for palliative?
I wish I could say yes, but no. And COVID sort of created more challenges. So there were over 30 demonstration projects across the United States for concurrent hospice care, and so concurrent treatment and hospice care, which they are very effective in terms of providing services to patients. They do see that they reach patient populations that would not have otherwise been reached by hospice. For instance, patients who are on dialysis with end-stage renal disease or malignancies who are still actively undergoing treatment, sometimes in the ALS population. But these are demonstration projects. There's no, in the near future, or even more in the next 5 years, I don't see that there's going to be a reimbursement structure for program-based palliative care at a federal level. There are different things going on in different states. But in a federal capacity, no.
Alrighty. Dawn is asking, some insurance companies have limits on home care. Most times the billing codes have a modifier that indicates the service is hospice related and it will fall under the hospital benefit. Just commenting as to your earlier comments. And Betsy's asking, do you have any insights into getting palliative care for those with active, looks like OUD, and all the challenges, including their anxieties and provider attitudes?
Oh, so this is a big one. So OUD, I am assuming you're talking about opioid use disorder. So this is also geography dependent, and if you're, on what your access are to providers. One of the things you'd want to explore are, do you have pain management or palliative care clinicians or clinics who have prescribers who are comfortable with and will use buprenorphine? And I can say that in the Boston area, so at our academic teaching hospitals, our palliative care clinics that are affiliated with those urban academic medical centers, they are expanding their capacity to provide things like buprenorphine, but also concurrent pain management to, say, for instance, the patients with cancer who also have active or history of opioid use disorder. As you get away from academic medical centers, there can be less comfort level with this. I would say it's something that all clinicians, regardless of being in palliative care or not, in particular primary care, is being asked to do better with. And that, there's just been a huge policy change in terms of the waiver that was required, the X waiver for buprenorphine prescribing. That has now been eliminated as of January 1. And will be enacted this year. So there is no barrier for any clinician to prescribe buprenorphine, and previous to the X waiver going away, there was no barrier from like a DEA perspective if you were using it for pain. But you want to ask questions like, does anybody in the practice have experience with or prescribe buprenorphine? Does this practice feel comfortable with or have clinicians who utilize methadone? Do they have interdisciplinary support? So is there social work or LMHC support for this patient population in addition to the prescriber or the medical care that's going to be required?
Hey, do we have any additional questions for Nicole? Any additional questions? Nicole, it looks like we've answered all the questions this evening for you.
Yay!
Awesome. Mary?
Thank